Recording in progress.
Hi, everybody. My name's Michelle Dawson, and I am the host of First Bite, an SLP podcast. And I am so incredibly grateful that you are joining us here tonight to kick off empowering providers through the PFD journey. This passion project that has been pulled together by volunteers from across the nation truly is a labor of love. And I know those of you that follow First Bite are well aware that I am right there in the trenches. I am an early intervention speech language pathologist. Monday through Thursday, I'm with patients. Fridays, I'm podcasting and volunteering and apparently baking brownies for science projects. But this entire series started because of a breakdown in communication between myself and other providers. And it resulted in a delay in a child getting a referral. And so I took that life lesson and was like, how can we create a opportunity? How can we create a space where different interprofessional practice providers can collaborate and care? There's a Japanese dish. It's called Kingstao. And when this piece of pottery is broken, they put it back together with gold. And to me, that's what this project is. This is the gold. This is us creating that space to learn alongside each other. And I just truly want to thank the physicians, the speech pathologists, the psychologists, the caregivers, everybody who has volunteered time to see this webinar series come together. So if you are in it, if you live this, if you are a caregiver, if you're a provider, this is your safe space. So I want to thank you for joining us. I know we have almost 200 on live. There's 850 registered in total for tonight. So thank you for choosing to be a partner. All right, so housekeeping. You do need to, at the end of today's session, log into Speech Therapy PD and complete the survey. That way you can get your certificate of attendance if you're not a speech pathologist and your ASHA CEUs if you are a speech pathologist. Currently, there's no handouts. We'll upload to the dashboard and you'll be able to access those afterwards when they come. And if you want to catch this video on replay, in a few days, you'll be able to find it on the Speech Therapy PD YouTube channel. So make sure that you check out the Speech Therapy PD YouTube channel. You can share the video on YouTube with anyone and everyone, because again, we're hoping to share the knowledge. So without further ado, I get to pass the baton to some amazing folks. Dr. Amy Delaney, who is a lead speech language pathologist in the world of pediatric feeding and swallowing disorders. Everybody go check out her page, Peds Feeding Lab at Marquette. I'll be sure to add that into the chat box. And Dr. William Sharp, who is a lead psychologist and the head of CHOA's feeding program. And Jaclyn Pederson, who is the CEO of Feeding Matters, will be attending virtually pre-recorded because she is off saving the world, because that's what she does. She's kind of cool like that. So, Amy, I'll pass it to you. And again, everybody, thank you so much for coming on.
Hi, everybody. We are going to share our screen and share the message. In the first 20 minutes is Jaclyn with a whole bunch of information. Michelle, can you everybody see everything?
Yes, ma'am.
All right, let me just make sure I shared it with audio because we know how that goes. Goodness gracious. Yes, indeed. Okay. All right. Here we go. Let me know if you can't hear anything.
Hello, everyone. I'm Jaclyn Pederson, CEO of Feeding Matters. I am here with you via pre-record, but later on you will have Dr. Amy Delaney and Dr. Will Sharp, who will be sharing a lot more information. But thank you so much for being here. This month, May, coming up, is PFD and ARFID Awareness Month. And so kicking it off, Michelle brought us together as she does, and so excited to be here with you all. So without further ado, we're going to go over It's Not Picky Eating, a Foundation for Pediatric Feeding Disorder. Now, before we get into the content of our presentation, I do want to acknowledge the disclosures that are up on the shared screen. That includes financial and non-financial disclosures for our facilitator, Michelle, myself, as well as Dr. Sharp and Dr. Delaney. Now, what I will be sharing today before I kick it over to Dr. Delaney and Dr. Sharp is about Feeding Matters, just a little bit of information, and later on in the program I'll be sharing some resources, and then about PFD via some modules, and then a pre and really post survey as well. We are hoping that in sharing these modules with all of you today, you might be open to participating in the research study that we currently have open with Emory University for doing these modules. So I'll share a little bit more once we get to that point too. So Feeding Matters is a system change nonprofit and advocacy organization. We are a 501c3 nonprofit organization. We are headquartered here in Phoenix, Arizona, where I'm located, and we have a national and international reach and work with many partners across the country and world. We were established in 2006, and so we are celebrating our 20th anniversary. And it's a great moment for us to not only celebrate how far this field has come, with hopefully a big part of what we brought to that, but also to really think about where do the next 20 years need to go. And that's what I'm hoping you all can help us with today too. Really hoping that this time together today, you can learn a little bit more about PFD if you didn't know as much about PFD, or maybe share your feedback and how you're coming and approaching this conversation for us to really take back and think about how do we need to progress this field. So Feeding Matters is the first organization in the world uniting the concerns of families with the field's leading advocates, experts, and allied healthcare professionals. We really take and keep like a very big responsibility of ours is to build bridges and make sure everybody is collaborating in this field, really to support early identification of PFD and ARFID. So up on the screen is a QR code. Hopefully you have your phone on you and can take out your phone and take a picture to get to the link that is shared on this screen. This link will take you to the IRB information about this research project. And so really today we are sharing the 6 modules that are part of this research study. And so it's completely your choice if you want to participate in this study, but we figured as long as we were sharing the modules with you all, you might be open to filling out a pre and post survey as well. So if you are open to filling out a pre-survey, please go ahead and follow that link. You'd have to scroll through a lot of the text and information that is shared about the project. I will also be reading it while you are looking through it. And then you can affirm that you are open to pursuing and participating in the research study in this way. And then you will be asked around 15 questions that shouldn't take you more than a few minutes to fill out. These include demographic information as well as a little bit of pre-survey information just to get a sense of your baseline awareness of PFD. So essentially, the link, if you're following it right now, is a link that shows that you're being asked to be in a research study. And if you agree, you would be one of the 700 people we are hoping to get to fill out this survey. This study is being done to evaluate a new physician and provider-facing educational intervention designed to increase awareness and knowledge of pediatric feeding disorder. And so you are being asked to participate in this as a provider. Completely optional to you. It is your choice to join this research study. You do not have to be in it. But if you choose to, we really appreciate it. We will be sharing the modules with you all no matter what. So then once you, and hopefully you all are in your pre-survey if you are filling this out right now as a provider. So hopefully you're filling that out, answering questions about your practice, primary care provider practice, and answer to the best of your ability. All the questions are optional. This is considered a low-risk study, but there will be no cost to you. And then once you've read this form and fill out the survey, we will move on to the modules. So I think we're pretty close to being able to continue on. So hopefully you've had a chance to use your phone to scan this QR code, to read the information, and then to fill out that pre-survey. Once you've filled out that pre-survey, you will be brought to a page which has all of the different modules on it. But what I will say is we are going to play those now, so don't worry about playing those on your own device. You will be able to then do the post survey once you've watched them from us. And I will be honest with all of you that this is a your guinea pig group to do this with. We've only just started recruitment for this study, so we only have about 40 participants so far. So welcome all ideas as well. If you are finding any challenges, please provide that in the chat. And this is work that we are working on in partnership with Dr. Will Sharp. If you do have any questions, you are happy to ask him, and then we will move on. I will play each of the modules. They only take a few minutes each. There are 6, and I will just move from one to the next. I won't provide any commentary in between. So thank you.
Most children enjoy meal times and eating. Trying new foods, sharing meals with family, having favorite treats at celebrations, and their diet is sufficient for healthy development. But for some children, eating just isn't that simple. Have you ever worked with a child who has difficulty eating an adequate volume or variety of food, struggles with feeding, or isn't growing as expected? It's not just picky eating. This may be pediatric feeding disorder, also known as PFD. PFD is included as a diagnosis in the International Classification of Disease. PFD is a multifaceted condition affecting a child's ability to meet their nutritional needs through eating and drinking. It isn't just about food preferences. It's a complex condition involving 4 key domains. Children are at risk for PFD if there are underlying or pre-existing challenges in one or more of these domains. Medical: conditions that impact structure and function of the GI, cardiorespiratory, and neurological systems. Nutrition: challenges in maintaining proper hydration and consuming a balanced diet to support development. Feeding skills: impairment in oral sensory functioning, oral motor functioning, and pharyngeal motor functioning. Psychosocial: emotional and behavioral factors affecting a child's relationship to food. Assessment and treatment of PFD should consider all 4 domains to identify all factors that contribute to restricted food intake. Identification is important because PFD is common. It affects as many as 1 in 23 children. It can affect children from birth through 21 years of age and may be acute or chronic. PFD doesn't just affect children, it impacts entire families, causing stress, disrupting social events, and even creating financial strain. Early detection and intervention make all the difference. If you suspect a child has PFD, ask caregivers about their concerns and use the Feeding Matters Infant and Child Questionnaire as a screening tool. By recognizing the signs and making timely referrals, you can help children and families navigate this challenge and build a healthier future. Learn more about PFD and its key domains, and visit feedingmatters.org for additional information or to find support. Most children. The medical domain of pediatric feeding disorder focuses on identifying and treating medical conditions that contribute to or cause feeding difficulties. These underlying issues can make eating difficult, painful, or unsafe, and they are often at the root of a child's struggle to eat and grow. Medical conditions often associated with PFD include cardiorespiratory compromise during feeding, aspiration or recurrent pneumonias, and complications related to prematurity, neurodevelopmental disorders, and GI conditions like severe reflux or food allergies. Children with medically based PFD may show signs such as labored breathing while eating, vomiting, chronic respiratory infections, coughing, choking, or arching during feeding, wet breathing after drinking, crying, and suspected allergic reactions to food. Medical providers are often the first to identify PFD and play a key role in screening for signs across domains, ordering diagnostic tests to uncover underlying causes, and collaborating with specialists in the nutrition, feeding skill, and psychosocial domains for a full picture. Diagnostic evaluations may result in medications, dietary modifications, or surgical procedures such as airway surgery or feeding tube placement, depending on what's contributing to the feeding challenges. Since PFD is complex, early screening and referral are essential. We encourage providers to ask families about feeding concerns and use tools like the When to Refer RAC card and the ICFQ 6-question screener, available at feedingmatters.org/educational-materials. Understanding the medical domain is only one part of recognizing PFD. To fully address feeding challenges, we encourage you to watch the rest of this series, covering nutrition, feeding skill, and psychosocial domains. And visit feedingmatters.org for additional information or to find support. The nutrition domain helps identify and address eating challenges related to pediatric feeding disorder, or PFD. Nutrition is essential for growth, brain development, and overall health. It impacts motor skills, cognition, and a child's ability to thrive. PFD-related nutritional challenges often show up as poor growth, vitamin or mineral deficiencies, or heavy reliance on formula or tube feeding. Registered dietitian nutritionists play a key role. They monitor growth and dietary intake, assess food variety across major food groups, conduct food recalls and nutrient analysis, and order blood tests when necessary. Dietitians may recommend formulas or supplements, collaborate with feeding therapists on identifying treatment goals, and/or adjust nutrition plans as a child moves away from tube or formula dependence. Providers should collaborate with dietitians to identify nutrition gaps to improve outcomes. Growth charts are useful, but height and weight don't tell the whole story. We encourage providers to look beyond the growth charts and consider food variety and intake patterns. Understanding the nutrition domain is only one part of recognizing PFD. To fully address feeding challenges, we encourage you to watch the rest of this series, covering medical, feeding skill, and psychosocial domains. And visit feedingmatters.org for additional information or to find support. Feeding skill challenges are a core aspect. Feeding skill challenges are a core aspect of pediatric feeding disorder, or PFD. These impairments affect a child's ability to eat and drink safely and efficiently in an age-appropriate manner. Children with medical complexities, neurodevelopmental concerns, or disrupted feeding experiences are at higher risk of developing feeding skill impairments. Signs of feeding skill impairments include coughing, choking, gagging, difficulty transitioning to new textures, or unusually long or short meal times leading to poor intake. Feeding concerns are often evaluated by occupational therapists or speech-language pathologists trained in eating, feeding, and swallowing. They obtain a feeding history, assess development, conduct feeding and swallowing evaluations, observe meals, and may recommend imaging. Feeding specialists establish safe, functional, and efficient mealtime skills. Interventions may include adaptive seating or utensils, diet or texture modification, feeding and mealtime techniques, and caregiver coaching. Providers should refer to feeding specialists when concerns arise. Use the When to Refer rack card from Feeding Matters to spot red flags. Understanding the feeding skill domain is only one part of recognizing PFD. To fully address feeding challenges, we encourage you to watch the rest of this series, covering nutrition, medical, and psychosocial domains. And visit feedingmatters.org for additional information or to find support. Feeding skill. The psychosocial domain of PFD focuses on evaluating and addressing psychological and social factors that contribute to feeding challenges. This includes emotional struggles in the child, tension between the caregiver and child during meals, or mealtime habits that unintentionally make feeding more difficult. Children may refuse food, become upset during meals, prefer grazing without structured mealtimes, or disengage entirely from eating. Caregivers may respond by giving rewards, distracting, making special meals, or even giving up on shared meals. Psychosocial providers collaborate with medical, nutrition, and feeding skill experts to assess mealtime behaviors, routines, and the feeding relationship. Psychosocial interventions may gradually introduce new foods, modify mealtime structure, and support caregivers with effective techniques. Feeding struggles can strain families and increase the risk of PFD. It is important to ask about mealtime stress, routines, and emotional responses from both the caregiver and child. Understanding the psychosocial domain is one part of recognizing PFD. To learn more, visit the other domain videos and watch the final video exploring the lived experience of families. And visit feedingmatters.org for additional information or to find support. Family experiences during mealtimes often hold the earliest signs of pediatric feeding disorder. Medical providers play a critical role in identifying mealtime concerns and supporting families. Without appropriate recognition, feeding concerns often grow increasingly problematic and impactful. Red flags for pediatric feeding disorder, or PFD, can be difficult to identify when they first occur. Timely identification requires looking beyond what or how much a child eats and asking how a family feeds their child. Although culture impacts how mealtimes look, universally, families should describe mealtimes as enjoyable. PFD varies in presentation. Concerns may look different for each child. For example, a family may feed their new baby every hour or when asleep for the baby to get enough calories. Ask, are mealtimes stressful or exhausting? A toddler or school-age child may refuse purees or table foods and rely solely on liquids for nutrition. A child may need preferred activities, screen time, or rewards to eat. Ask, can your baby eat textured foods? Do you have to distract your child for them to eat? A child may abandon mealtime or have outbursts if new or unpreferred foods are offered. Ask, do you have to give your child specific foods, such as only fast food, or prepare foods a certain way for them to eat? If families describe highly effortful or emotionally charged mealtimes, a deeper evaluation is needed. As providers, we can help uncover the reasons mealtimes may be so difficult. Helpful tools include the ICFQ 6-question screener and the When to Refer RAC card, both available through Feeding Matters. Understanding the family experience is one important piece of recognizing pediatric feeding disorder. We encourage you to continue exploring this series covering the medical, nutrition, feeding skill, and psychosocial domains, and visit feedingmatters.org for additional tools, education, and support.
Thank you so much for following along with those modules as we shared a little bit more about PFD and all of the different domains as well as the lived experience. Now, if you've got your phone still out, please follow the instructions on it to fill out the post survey from the modules. And I will be turning it back over to those who are with you live, Dr. Delaney and Dr. Sharp. Thank you for having me.
All right. Michelle, do you want to MC while I get a little set up here?
Absolutely.
Hello, everyone. I'm Jaclyn Pederson, CEO of Feeding Matters.
Exactly.
Okay. So folks, gentle reminder that this August, Feeding Matters is hosting their Psychology Summit. It will be live on Friday, August 31st. And if you can't make it on Friday, August 31st, because I completely understand life happens, vacations are still going right before the start of school, it will also be on demand for the month of October. So I've added that link right in. Additionally, don't forget to sign up for next Thursday's Point One ASHA CEU, which is the part 2 of our series. Dr. Richard Noel, who is a GI specialist, as well as Dr. Tessa Gonzalez, who is a pediatrician and a caregiver of a little one with PFD. They will be presenting how pediatricians and specialists can work together for the PFD domain. Good.
Excellent. All right. Well, hey, everybody. So I am Dr. Amy Delaney. I'm at Marquette University. I'm a speech language pathologist by trade, and worked at Children's Wisconsin for 20 years, and have been part of Feeding Matters forever. And I'm just really happy to be here. And Queen Michelle is always bringing people together in just wonderful ways. It's just beautiful. So thank you for having us. I'm going to talk for a little bit about just feeding and feeding development in general. And so when a child has PFD or ARFID, they don't feel well. They, when my animations aren't working, there we go. They don't feel well, right? They struggle to eat enough, eat a good variety. And when this happens, there's this negative dynamic in the family that creates a lot of stress. So, why does this happen? Well, feeding development is so complex. It's the only human task that involves every single organ, integration of all 8 sensory systems, perfect harmony of 26 muscles, 6 cranial nerves for just one swallow. And that's when everything is working beautifully. And this is all dependent on this intricate coordination across developmental areas. So I like to talk about the first 1,000 days, but also beyond. So feeding development is a progression across childhood, and that end mature point, we're not really sure when that actually exists. But we're going to talk about the first 1,000 days first. This is the period of time when most of human development is accomplished. Okay, so this is the time that begins at conception, and it relies on maternal health and nutrition throughout gestation. And then in early infancy, proper nutrition supports brain development, the infant's ability to build a healthy microbiome, and support adequate growth. So the infant, though, and we as clinicians are dependent on the caregiver and the resources that the caregivers have and their feeding choices that they make throughout infancy related to the type of nutrition that's offered, when new foods are introduced and subsequent food exposures, parenting factors and styles, social cultural feeding practices, environmental issues, etc. And all food, texture, utensil, self-feeding transitions all occur in these first 1,000 days. And this is dependent on the acquisition of appropriate feeding skills. So no small feat here. So we have this interconnected system where each factor is influenced by and influences the other. So we know that there's multiple developmental domains simultaneously developing across this time frame, but on different timelines, to make that a little hard, occurring at different rates, influencing the other. And this is really forming the basis of feeding development. So when there's a disruption in this, any of the developmental sequences, we may have neurodevelopmental delay and difficulties in skill acquisition. So we know if we have a delay, it's likely to influence feeding skill acquisition, and delays in feeding skill acquisition are likely to negatively impact nutrition. And what's really important is that undernutrition in the first 1,000 days is a major predictor of compromised function in early childhood. And in fact, undernutrition during this time can lead to irreversible neurodevelopmental delays. So, this is a highly critical window of time that we need to be monitoring children, across the span. But fortunately, it's also the critical window of opportunity or interventional opportunity, meaning that it's the time in the child's life where they benefit most by interventions, as long, of course, as it's provided at the appropriate time and with effective strategies. So, sorry, that is my dog. So it makes understanding feeding developmental trajectories during this time really extremely important to understand. Piper, you're fine. So the benchmark for PFD age-appropriate feeding is what we are striving to understand. This is our reference standard that allows us to support a diagnosis, that allows our families to access treatment and specific interventions. But, how do we know? So, we think we have this kind of clear feeding developmental trajectory, and we can think about it along this continuum. But where these critical stages occur are still really unclear. So, in a lot of work that's out there in some of our current work, we study healthy young adults to determine the end of this kind of developmental trajectory. Let me close my door. So sorry. Bert? as such as live work. Okay, not distracting at all. So we're interested in how healthy young adults at that kind of mature endpoint are functioning, and we use that to gauge all preceding development along this developmental continuum. So we study really young infants all the way up to our healthy young adults. And what we know about feeding skill progression in the current literature is that we have general consensus on developmental progression of feeding skills. And we know from the literature that different feeding skills are elicited by different textures, by different utensils and devices as they're consuming nutrition. But since we know that in these first 1,000 days that it's so critical in identifying dysfunction, these phases of progression that we do know are just not adequate. And it underrepresents the complexity of feeding. And we know missed or altered or delayed exposure to any of these because of a diagnosis, an illness, that it increases our risk for feeding and swallowing challenges. So when we think about PFD and the diagnostic criteria, across feeding development, we expect children to eat safely. We expect them to consume their nutrition efficiently. And we do this with age-appropriate skills. Safety and efficiency are not dictated by age, right? All children, all adults should be eating safely and efficiently. Feeding skills, though, however, are age specific. And that is what we struggle with across the feeding developmental continuum of understanding when it's appropriate to identify a child as having difficulties and enrolling them in therapy, right? That's our clinical struggle always. So we know that our feeding skills are dependent on adequate structure, function, appropriate sensory responses, appropriate motor systems in both the oral and the pharyngeal mechanisms for eating. And so we need to understand how these structures and functions support things like texture progression, advancement of utensils and devices, appropriate seating and positioning, self-feeding, and the types of strategies or assistance that we need. And so I have aligned my research program in determining age-appropriate markers for each of these criteria. All right, let me check one thing. Okay. It's always computer stuff. Okay. So ultimately, we are studying biomarkers of feeding skill development in children both with and without feeding disorder. And really our mission is that all children deserve healthy, safe, and positive feeding experiences. And we're doing this across most of childhood, but also, like I said, into early adulthood, so we can really understand what this progression is. So we're trying to move away from clinical description to true measurement so that we as clinicians can use different measures that we have available to us, physiologic measures, cranial nerve exams, oral feeding skill observations, acceptance refusals, bite durations, texture consumption, all kinds of work that we do so that we can measure what we're doing clinically to justify diagnosis and justify therapy and actually track therapy progress ultimately. And we are really interested in how all those different developmental domains influence all of these features across age. So where we go from here is we are, as a field, trying to understand the gaps in our clinical knowledge. I think we've talked about, we have insensitive time periods, we have missed or incorrect interventional time because of delayed identification. We need better measurements. So we're going to take all of this clinical experience that we have. We're building this into our research program, and not just myself, but there's a nice variety of people that are doing peds feeding research. And we're trying to understand the system. What are the varying timelines across these skills and variables? what are critical phases so that I can confidently identify a child at different age points? What are the different types and amounts of experience and feeding practices and how that contributes to feeding development in positive or negative ways? And what are those other influencers that we need to be cognizant of? And certainly as clinicians, we're always thinking about this intersection of structure and function and environment. We have to take all of those into consideration. And with all of that understanding and work, we can refine clinical practice in understanding then when things go wrong, how does that impact the trajectory? And that will help us to identify appropriate timing and types of interventions and really tailor these for clinical feasibility. So when we think about our littles, we know we have littles that are really low risk, and maybe we could prevent PFD by having better maternal education and resources, or caregiver education and resources regarding nutrition and health and early feeding practices, definitely ongoing education and resources for other providers, better access to feeding guidelines and expectations, and of course, early and often screening and making feeding its own developmental domain. And there's a lot of kids that we just can't prevent PFD, but we can certainly protect them from more protracted and severe PFD by identifying when we have these perturbations in the trajectory in congenital heart and Down syndrome, et cetera, and what the risk factor is, so we can tailor our surveillance and screening early and often and at the appropriate times, and have earlier access to interventions and targeted strategies. And all of this should better support nutrition and development for those better outcomes. So the goal here is to really, I think, look at feeding development as a really complicated, wonderful thing that we all have been struggling with. We need lots more work to do to understand it better, which will help us in all of the work that we do with our kids with PFD and ARFID and navigating the differences between those. So with that, I'm going to turn it over to Dr. Will Sharp, and he's going to talk to us about PFD and ARFID. All right.
I'm on. Can you hear me? Yeah.
Yes.
Okay, good. Hi, I'm Will Sharp. I'm here at Children's Healthcare Atlanta and at Emory University. I run a large multidisciplinary feeding program, and I'm also run a research lab. So happy to be here, and we can go on to the next. All right, so dating probably even before the 1940s, we've had a number of terms to describe dysfunctional impaired food intake in children. The first attempt being things like maternal deprivation, infantile anorexia, non-organic, failure to thrive, and so forth. We had our first real diagnostic attempt in '94 with feeding disorders of infancy and early childhood in DSM-4. But it wasn't really until 2013 when DSM expanded the previous diagnosis of feeding disorder of infancy and early childhood to be ARFID, avoidant restricted food intake disorder, that we started getting a lot better diagnostic clarity. And then in 2021, PFD was introduced into the diagnostic nomenclature in the ICD-10. It was actually introduced in 2019 in a study, and then in 2021. And these two diagnoses have really advanced the field in many ways, but they've also created some confusion that I'll be going over today. All right. So for those of you who are not familiar with avoidant restricted food intake disorder, or ARFID, it is a psychiatric diagnosis. It involves a hedonistically negative relationship with food driven by one or more of the following expected aversive outcomes. So the first outcome is fear of aversive consequences. These tend to be children who have an experience of pain or uncomfortable eating. Think about children born with prematurity with in NICU that have complex GI conditions. Those kids with complex medical are really at risk for this first type of ARFID. You also have disgust, distaste. These are the heightened sensory children who have a different experience with the sensory aspects of food. So I've had a child who walked into a food court, all the smells came, and she projectile vomited from the overwhelming nature of all the food smells and taste. And then the final group are patients who have poor appetite or limited interest in eating. These are kids who really lack motivation, and all three of these are they're biological underpinnings to these conditions. So this isn't just these are grounded in neurology, and so just to be aware of that. All right. And then in 2019, I sometimes want to say to confuse things a little bit, but I think it actually drove the field forward. In 2019, Godet, and I'll explain the confusion part in a second. Godet and colleagues, and Amy was part of that as well, introduced pediatric feeding disorder through a consensus definition and conceptual framework. And as the modules that we developed in collaboration with Feeding Matters show you, it's a multidisciplinary diagnosis. So the ARFID is the psychiatric diagnosis. PFD is a multidisciplinary diagnosis that's looking at impaired oral intake that's not age appropriate and is associated with medical, nutritional, feeding skill, and psychosocial dysfunction. Hopefully everybody's an expert at this point from watching the videos today. All right, so when I said confusion, so this is a resource available that we developed at feedingmatters.org. But if you go and look at the two definitions, ARFID and PFD, they have verbatim, I would say almost verbatim, but they're pretty almost spot on similar in terms of the diagnostic criteria for the nutritional and the psychosocial aspects of the impairment. Now, ARFID excludes kids who have an ongoing medical issue, because ARFID is supposed to be about learning that food is painful or uncomfortable or something you don't. It's the psychological aspect of eating, right? So PFD, we're increasingly understanding that PFD is the home for children who can't eat because it's not safe for them to eat. So they aspirate, they have cardiorespiratory compromise, any kind of issue related to eating that causes pain or discomfort. And feeding skill issues. So these are kids who may not have the skill to appropriately masticate foods, might have difficulty, coordinating the idea of chewing, swallowing, and consuming food. Maybe some issues with self-feeding. So that's really what PFD is starting to fill the gap for. So while I said it was confusing, it also did fill a much-needed gap in the field. So beginning in 2023, 2024, in collaboration with Feeding Matters, we brought together experts in the feeding and eating disorder world to start trying to better understand, in the pediatric feeding disorders world, to try to start a better understanding how we can bring further clarity to the overlapping and somewhat confusing nature of the two diagnoses. So I'm going to hope in the next 5 or so minutes give you some clarity. Hope so. So we're going to talk about what we found. Okay, so we came up with 10 consensus statements. By the way, this paper's open access, but if you go ahead and click, I got some animation going on. I think I do, yeah. So I'm going to talk about 4 of the statements, and then I'm going to go into further clarity. So statement number 2 is that there's clear diagnostic overlap between PFD and ARFID, but both definitions would benefit from further clarity regarding how to navigate this overlap, because the two no, okay, I'll get to the questions a little bit. Neither diagnosis even references each other. And the relationship, so number 3, the relationship between PFD and ARFID is such they can influence one another. Criteria can be met for both conditions, or they can exist in isolation. And the panel and the paper discusses 4 different scenarios, which I will go over this evening. All right, go ahead and click the animation for me. So number 7, PFD that transitions into ARFID likely involves a different causal pathway than ARFID that develops in isolation. Age of onset, learning history with food and eating, a disorder course, among other developmental and learning histories, are important considerations in the diagnostic relationship. And when you develop ARFID, once again, both pathways of ARFID development involves a negative association with food. And then finally, age of onset is an important consideration. Both ARFID and unresolved PFD may be present in adulthood. So you can be a PFD patient that grows up to be an adult and still have PFD, but only ARFID can emerge when you're an adult. Next slide. Okay. And the importance here and this is in the paper as well, is up through middle childhood, you still have the feeding skill developmental window occurring. So, children from birth's really amazing, right? You come into the world, you can only drink liquids. And within a relatively short period of time, as Amy's work, really accentuates, we are learning very rapidly to become expert eaters. And by the time we get to middle childhood, we have reached full autonomy. And the reason it's important or middle to late childhood and preteen, but the reason this developmental window is so important is when the window's still open, if you develop ARFID, you could actually develop ARFID could actually cause PFD, and I'll explain what I mean by that in a second. Next slide. So in the paper, we discussed 4 different scenarios. Scenario 1 is when PFD exists in isolation, and then you see when that feeding developmental window is occurring. Scenario 2 and 3 are when they can start to influence each other. PFD and ARFID can start to push on each other. And then scenario number 4, adolescence, adulthood, is when ARFID can exist in isolation or come about in isolation. Okay, so here are the 4 scenarios. PFD occurs in isolation. So PFD often involves medically complex infants and young children with conditions that prohibit safe feeding. So basically, kids can't eat safe because they're aspirating. They have significant oral motor deficits that's causing feeding to be really fatiguing. Or they're having significant pain while they're eating. And so their rejection or avoidance of food makes sense because it's causing pain or discomfort or fatigue. And when food restriction can be directly attributed to medical conditions, it excludes a diagnosis of ARFID. So it can't be ARFID in that case. Or if the food restriction, if the food restriction may resolve with if you do medical intervention or feeding skill intervention and the food restriction resolves, that's not ARFID either. So that's PFD in isolation. Next. So it's also the case that PFD can transition into ARFID. So we know that some medically complex children they're going to go on to develop conditioned food aversion when unpleasant consequences are repeatedly paired with eating over time. We know that conditioned taste aversion is very simple to condition in humans and other animals. So you get sick one time, you don't go eat that food again. So imagine if every time you eat, you're getting sick and the medical issue resolved, but the behaviors that went into avoiding those foods remain because those behaviors are so effective at this point. When you see PFD transitioning to ARFID, it's also really important that you continue to monitor per PFD for the reason I'm about to do on the next slide. Okay, so it's also the case. This was one of the more interesting aspects of the consensus meeting because I'm an ARFID. I treat ARFID. That's kind of my area of expertise. We screen for PFD, but I hadn't thought about ARFID causing PFD. And so the idea here is if you're restricting food, say you're like a 5-year-old, you've gone through many of the developmental sequences that you needed to become, a table texture child, but you develop ARFID and you don't continue to develop your feeding skill along those lines. So this is when ARFID subsequently holds the potential to impair further feeding skill development if the avoidance and restrictions limits further food exposure or other mealtime experiences, including learning how to self-feed that has yet to develop. It's also important to note here that both PFD and ARFID can be met at the same time. And if they are met at the same time, your intervention would likely require consideration for both the avoidant behaviors that go into avoiding food, as well as potential skill-based deficits. And that's why for really severe chronic feeding issues, we recommend a multidisciplinary team approach with both SLP and a psychology or psychosocial provider coordinating care to make sure we're not missing anything that may be causing difficulties with oral intake. All right, I think this is my last slide. And then finally, ARFID occurs in isolations. So we know that there's some adolescents and adults who go on to develop ARFID have a history. They'll say, I've always not been the best eater, but I was able to get by. I was able to achieve all the feeding milestones I was supposed to. It's almost like a prodromal symptoms were there, but they hadn't fully developed it. And then when they get older, the impairment associated with those eating restrictions really emerge into a disordered pattern of eating. So that's one way ARFID develops. We also know from the literature that food-related traumas such as choking or new onset appetite loss can occur at any age throughout the lifespan, and descriptions of older children, adolescents, and adults developing ARFID have been well documented in the eating disorders literature. In fact, one reason ARFID came to exist is because the eating disorder community was saying, we're seeing older kids without anorexia or without bulimia, but they're restricting their food intake, and it's occurring in an older cohort of patients. And that's one influence for the ARFID diagnosis. All right. I think I ended with 8 minutes left. I think that was, yep. So we got questions. How are we doing questions tonight?
Yeah, well, we have a little bit of from Jaclyn yet.
Okay, cool.
I just need to pull that up. Michelle, do you want to work on that?
Yes, I can get us going.
I will pull up the last video.
Okay, so Will, to kind of get us started, and this is a great question. One of the attendees wants to know, how do we reconcile the fact that many children with PFD have underlying undiagnosed medical conditions, for example, GI, that impact their feeding, along with the fact that psychologists are diagnosing ARFID without confirming a lack of underlying medical diagnosis?
Yeah. So if ARFID is suspected, the standard of care should be a thorough medical workup to begin with. So like that you should never start with a behavioral intervention ever. That's like the biggest no. So I would say hopefully this kind of venue to talk about this is that if you're having a provider that's starting with an ARFID diagnosis without a medical evaluation, they need to go and read our work. I think that's in the consensus paper as well. We say must start with medical. Always start with medical.
Yes.
And then after medical, you go to feeding skill. And then after feeding skill, you come to us.
Yes. Folks, it can be actually pretty hard to find a psychologist that works with feeding. I know, having lived in South Carolina and then up here in Virginia, I've had to learn a new network, a new group of colleagues. But Feeding Matters actually has a provider list on their website for free, where you can go in and enter your region, your zip code, or even find some providers that do telehealth. Also, if you truly live in an area, and we're all aware of those, where you don't have access to one and the family can't afford to make it to a specialist, Feeding Matters has a scholarship that the families can apply for to help offset the cost of getting to the specialist. So I'll make sure to add those, the link to the scholarship and the provider directory into the chat box for everybody.
Great. Michelle, it's a 3-minute video left from Jaclyn with all the resources. We can do that, and then we can wrap up with some questions.
Yes, we have quite a few have popped in. This is great. I love the questions.
Awesome. All right.
I'm back to share some patient and family support resources in case you do see a lot of these families and want to be able to share some resources directly with them. The easiest one that I'm going to mention today is itsnotpickyeating.org. That's itsnotpickyeating.org, and that has the easiest way for families to engage with this information and a lot of the support resources that we offer families. As you saw in the modules, there's the screening questions that we have that's also available on that website, as you see here. We then have other resources for families. There's a family guide for PFD. We actually have an ARFID guide coming out soon. It's just still being worked on, so it'll be a few months before that comes out. We have family financial assistance, as we know this is a really big burden for families. And then we have an empowerment cohort for families that may be waiting on wait lists for feeding intervention. We have a Feeding Matters app and a school toolkit. We also know that one of the biggest challenges that families experience is really feeling alone in this, like no one understands what they're going through. And so that's why we offer Power of Two parent-to-parent support, where we connect one family with another family who has gone through something similar, or they maybe just want that listening ear. These volunteers of our organization are coached in trauma-informed support to be able to really sit with these families or parents or caregivers and really support them emotionally with what they're experiencing. Sometimes it's just listening and sitting there when a family is facing not a lot of great answers. And then last year we published a book called In My Own Way about PFD and ARFID. And really it's a book kind of celebrating a child being able to take their feeding journey into their own hands. So it's just a book to raise awareness, but also a lot of our little ones see a lot of themselves in this. We know that one of our families, her son's preschool class reads the book together all of the time, and they always know Ollie's going to do what he wants to eat, and he's going to take care of himself. And so it's a great book, especially for kids. Now, in your clinic, there's clinical support tools that we offer for professionals as well. As you saw in the modules, the infant and child feeding questionnaire and the when to refer rat card are all available on that feedingmatters.org educational-materials link. In addition to those are feeding flock tools, which you can find on Feeding Matters website as well. But these tools offer a little bit deeper dive. A lot of the other tools shared so far are more about screening, getting a sense for assessment, figuring out who to refer to, some of those things. These are what a lot of our providers and specialty providers use as it relates to feeding assessment and intervention. And so with that, here's our references, and I think we are turning it over to Dr. Delaney and Dr. Sharp for questions. So thank you all for having me and really appreciate being here.
That was great. Folks, I was rapid fire adding all of the links to the resources that Jaclyn discussed right into the chat box. Also, Feeding Matters has a podcast, which is so incredibly family friendly. So I added the link for the podcast as well. So I will jump in with the next round of questions. Lucia had asked a beautiful question about clarification on PFD versus ARFID, and can you have PFD if you only have one of the domains?
Okay, so that's really good. So you can have one or more of the domains. You can have PFD if you only, so remember PFD, the STEM definition is restricted oral intake that is not age appropriate. So you're looking at that restricted oral intake, and then it could be caused or have an etiological relationship to one or more of the domains.
Folks trying to do the assessment for PFD, there's a variety of tools out there. If you're just getting your feet wet in the world of PFD, I highly recommend you look at the resources on Feeding Flock because they're just so incredibly well built and they are all free. And there was some screening questions that came through earlier. Our early intervention team, we're in Virginia, and we actually use the PFD rat card, the 5-6 question screener, to help kind of guide caregivers when they're just listing those concerns out. And also that's free, but that was so incredibly well known. So, yeah.
And that was
Now,
based on the full questionnaire that's also on the website that has anticipatory guidance for caregivers. So you can direct them to the website, and there's a whole series of questions that give what by per age, what their child would be expected to do, and that it's considered potentially a red flag that they can then take to their provider to share that information, so that it's dually purposed educationally, but also to initiate that conversation with their primary provider.
yes, yes. Okay, so next question live. Do you have quick fire tips for ensuring that PFD doesn't turn into ARFID in a situation where GI issues or dysphagia have already been identified? Do we stop presenting those trigger foods until the issues have resolved? I've run into several toddlers where the fear is because it's a completely new experience, like our little G-tube babies, which causes its own host of issues. Oh, honey, I'm so going to encourage you to join us next week, right out the gate. But yes, Amy will.
Yeah, I mean, I think in that situation, we're still dealing with food introduction in a modified form that's meeting the skills of that child. Certainly that child's going to have delays in their ability, and that's where the feeding skill provider is really critical in ensuring that what we are offering is as safe and close to current skill as possible to avoid those negative situations. So if this child is experiencing, chronic negative situations around food exposures, we're presenting a mismatch in what their capacity is at that point. And so yes, could lead to some negative associations, but it's up to to that feeding skill provider to help navigate those.
Yes. Lori, I'll be honest, when I have some children that are so, we have such grave concerns for what could potentially be going on medically, you have the ability as the provider to say, hey, let's just focus on the safe foods. And you can even request putting a hold in therapy until the child's medically stable to then introduce new foods. And it takes grace and giving yourself grace and giving the situation grace to learn this is the time and the place to put therapy on hold and let's regroup in X weeks or after this surgical intervention or after this medication. That's okay too.
Yeah, because if we don't have a medical issue, if we have a medical issue that's contributing to their discomfort anytime
Yes.
they eat, we are going to make it worse. So, and that's where we pull in where the feeding tube is of such a great tool, therapy tool ultimately, and it also gives that child a chance to kind of reset. So those are hard conversations that we have with our families, but in essence, while families feel like it's taking that step back, it's really to help navigate and provide positive experiences and skill development outside of what they've previously experienced.
Yes. Amy, you have fans. Clearly I am one of them, but you have an additional one who says that they were one of your former students. And so shout out to Dr. Delaney. And they have a question. Is it true that there's a timeline for when interest or pleasure in eating develops? That they've heard that it happens by 18 months.
Yeah. Oh, sorry. You want the reference page, but it's in the video that I can't get. So that'll be part of the handouts. So I just saw that come through. Sorry.
Yes.
Yeah. So we know through particularly the first year of life and a little beyond where taste preferences develop. It's based on exposures. It's based on neuroplasticity, and integration of all of those reflexes and built on that culmination of experiences. So we do want to have exposure by 10 months of different textures and flavors. And there's a little bit of literature out there that shows that if those exposures occur post around 10 months, that it's actually much harder to learn to eat. Children are pickier, have a harder time expanding on their variety. And then we as clinicians are actually really teaching them to do it versus naturally acquiring these skills. And for some of our kids, we can't do that before then because of their health status or their safety. So we have to think about other ways to present the exposure to texture and flavors in non-nutritive ways or very small positive experiences that aren't necessarily to improve their nutrition.
Messy food play. I am the queen of a pie pan and trucks and making mud and all sorts of stuff, but having that exposure can really open doors, folks. All right, so Christy had a great question. Where can families find the power of two parent-to-parent support? If you go to Feeding Matters homepage, there's a giant orange button in the top left corner. It says Get Help Now. Click that button. Athena, one of the gurus behind the scenes at Feeding Matters, she talks about how hard it was for her to get the courage just to push that button. But that button truly, it's a lifeline for some of our caregivers. So click the Get Help Now. Athena, thank you for making that a perpetual joyful memory in my mind. Yes, and everybody, we're so glad that you've enjoyed this. If you have additional questions, please feel free to message us. I've added Dr. Delaney's contact information into the chat box as well as Dr. Sharp through LinkedIn. You can find me First Bite on Instagram. If you email me, it will go into a hole and I will never get to it. But if you send it to Instagram, I do answer it because I'm motivated by the dots disappearing, the countdown. Also, don't forget, next week we're taking this on a whole new level. We're going to talk about pediatricians and GIs. So for the questions about the G tubes, that would be a great follow-up for next week to listen to Dr. Richard Noel. Can you please place the link for the course quiz and evaluation in the chat box? Yes. All you have to do is go right back to your speech therapy PD dashboard and it'll be right there. I think that's all that we have time for because, good Lord, I know we could keep going. Dr. Will, Dr. Amy, any closing thoughts?
No, it's great to be here. Thank you.
Yeah, just grateful for everybody to be here and being open to information. And we know it was a lot all at once. We'll get a handout for you, but always just keep reaching out and go to Feeding Matters website. They have such a great wealth of information. That's a great place to start.
Yes. Well, everybody, thank you so very much for joining us tonight. And I will see you next Thursday at 7 p.m. for webinar 2. And make sure you finish your survey and sign up for the Feeding Matters conference here in August so we can spend a hot summer afternoon together. So thanks, everybody.